Yeah, so thank you very much. This is sunny Toronto, very nice city. You're all invited to come. These are my conflicts of interest working with many companies in the past and currently. And I'm trying to briefly make an overview of a rather old but still very, very relevant topic, which is intrinsic PEEP or auto PEEP. You can choose the best name. And the first thing to say is that the respiratory system can be considered in a schematic way as a compliance and a resistance. And with such a system, the expiration from a given tidal volume follows a mono-exponential equation. And this mono-exponential equation has a time constant, which for the respiratory system is a product of resistance and compliance, which intuitively I think makes sense. The higher the resistance or the higher the compliance, the longer it takes for expiration. And in such a system, we know that you need at least 3 time constants to expire almost 100% of the initial volume. So if you think of a normal resistance of 10 centimeters of water per liter per second, a normal compliance of 0.1 liter per centimeter of water, the time constant is 1 second, and you need 3 seconds for complete expiration. So if resistance is higher, compliance is higher, you need much longer expiratory time. If you don't have enough expiratory time, what happens is that you do not explode, but you progressively increase your lung volume until you reach a new equilibrium where the time constant is shorter. And that's why you have a state of dynamic hyperinflation, which is really the issue with intrinsic PEEP, where the end expiration is constantly above the functional residual capacity, which is the relaxing state of lung volume. The marker for that, as you all know, is the fact that the expiratory flow, and you see a nice decreasing exponential curve, is interrupted by the next breath before reaching zero flow. And so this visual marker, so you will note that the expiratory part of the flow is on the upper part, which is usually the contrary on the ventilator. So this is a marker that you have some degree of dynamic hyperinflation. You don't know how much is the intrinsic PEEP, although you could calculate if it's a very, using the equation I've shown. So the first message here is that for any patient in the ICU, shortening the expiratory time will create intrinsic PEEP. That's important to remember because intrinsic PEEP is often associated with COPD, and we will see why. But even in ARDS, by simply shortening the expiratory time, you will create intrinsic PEEP. This is a rather old study at the time where people were interested to use pressure control inverse ratio ventilation. So that would be a pressure controlled breath, which you all recognize with a decelerating flow. That would be the same breath with a prolonged inspiration and therefore a shortened expiration. And all the initial studies about pressure controlled inverse ratio ventilation said it's a fantastic mode because it increased oxygenation. And the only reason why it increased oxygenation is because it was generating intrinsic PEEP, which more or less has exactly the same effect that external PEEP. So again, if you look at the expiratory flow, you see it's interrupted. And again, another example in patients with ARDS, applying the ARDS net protocol of 6 ml per kilogram of tidal volume, but increasing the respiratory rate from 17 to 31. And in this study, we came the same inspiratory time, so which means the same peak inspiratory flow. we showed that this increase in rate was associated with a substantial increase in intrinsic PEEP. Whether it's good or not, it's not the question, but ARDS patients can have intrinsic PEEP, and that's important to check when you assess, for instance, the effect of a change in external PEEP. But there is another major reason to generate intrinsic PEEP, which is called by different names: expiratory flow limitation, small airway collapse, and which occurs especially in patients with emphysematous change in the lung. So again, schematically, it happens when the intrathoracic pressure becomes higher than the pressure in the small bronchi, and the diameter of the bronchi, because there is a loss of elastic recoil, the diameter goes down, or even the bronchi completely collapse. Again, the marker of that is a visual signal which is on the expiratory flow curve, where the nice exponential decay is replaced by a biphasic curve, where you have an initial expiration from the central airway with no collapse, and a second part of the expiration which is almost flat because it's only a small amount of air coming out from the almost collapsed bronchi. So this is not indicated by any number of the ventilator. That's just a clinical diagnosis when you see this type of curve. And this is a very nice illustration, I think, of using a high-speed CT imaging, showing in one patient with very severe COPD the diameter of small bronchi. It's not bronchioles, it's above, during inspiration, and the same one during expiration, and typical COPD patient with expiratory flow limitation. So that's also explain why when you try to calculate resistance, it may be very, very different at inspiration and at expiration. So in this case, when expiratory flow limitation is responsible for intrinsic PEEP, the relationship between the upstream pressure and your expiratory time is no longer what I described by the equation of the mono-exponential curve. It becomes almost independent of the driving pressure, and therefore reducing intrinsic PEEP in this case is much more difficult. So patients with high time constant and expiratory flow limitation like COPD are high risk of developing intrinsic PEEP, but they are not the only one. And for instance, expiratory flow limitation has been described in most patients with cardiogenic pulmonary edema, and even in patients with ARDS probably having very heavy lungs and a lot of compressing forces on the small bronchi. The nice typical example of this expiratory flow limitation is this type of curve. And again, if you see it on a ventilator, be aware that these patients has probably intrinsic PEEP, so you're sure the patient has intrinsic PEEP because the flow is interrupted, but this shape of the curve tells you that there is expiratory flow limitation. And to me, it's always extraordinary to see that despite having zero pressure on the ventilator screen, when you do an occlusion, you may have as high as 15 centimeters of water of PEEP. So the reason why this patient was oliguric, was requiring vasopressor, was only because he had a high level of intrinsic PEEP. So in this case, and this is the whole picture, in this case, the most important is not to do a very fine-tuning of the I/E ratio. The most important is to reduce the amount of volume you give to this patient. And this is illustrated in this nice study from Tuxen and Lane a number of years ago, showing that the hatch area is the amount of lung volume above FRC, so it's exactly dynamic hyperinflation. And here they try to play it for a given level of minute ventilation with the I/E ratio and expiratory time. So yes, it makes a little difference, but what makes a real clinical difference is decreasing minute ventilation and accepting higher level of PCO2. So it's not only just adjusting the ITU ratio, but thinking to accept lower level of minute ventilation. The other thing important to understand is the fact that these airways are collapsed or almost collapsed. And they are collapsed because the pressure outside is higher than the pressure inside the bronchi. So if you give an external pressure which is lower than this pressure, it doesn't make any difference. And this is illustrated by this waterfall explanation, where the top of the waterfall would be the auto-PEEP inside the lung, and that would be the external PEEP. And increasing external PEEP and up to this level does not change anything to the auto-PEEP level. And even if you put higher external PEEP than the internal initial auto-PEEP, you will simply increase lung volume. And this is a very nice tracing illustrating that. Just look at the airway pressure. This is during the expiratory occlusion. You see this patient has close to 10 centimeters of water of intrinsic PEEP. And this is a progressive increase in external PEEP. And if you look at the peak airway pressure, until you reach the same level or close to the same level, you do not see any change in the peak airway pressure. So your external PEEP is not doing anything to the dynamic hyperinflation. And this is very important to remember, because there is a major issue of confusion in the mind of many clinicians who think that putting external PEEP is good to decrease dynamic hyperinflation. And as you have seen, during controlled mechanical ventilation, whatever the level of external PEEP, until it's close to the internal value, does not change anything to dynamic hyperinflation. So if you ask me whether there is a benefit at using external PEEP when you have intrinsic PEEP in patients under controlled ventilation, I would say there is zero benefit. So why do we put external PEEP so often? It's because of spontaneous breathing. What matters during controlled ventilation is mostly hyperinflation and hemodynamic effects. This was shown in this beautiful paper from Paul Pepe and John Marini in 1982. This is a case series of 3 patients. This is the most important paper ever published in the field of mechanical ventilation in COPD. No evidence-based medicine meta-analysis will pick up this paper, but this completely changed practice. And what they showed is that when you disconnect the patient from the ventilator, you have an immediate increase in blood pressure, an increase in cardiac output, and this is purely mechanical, explained by the internal pressure. So during controlled ventilation, you want to reduce that because you want to reduce the hemodynamic problems and the risk of barotrauma. During spontaneous breathing, that's another issue, because during spontaneous breathing, to trigger the ventilator, for instance, the patient has to bring back the internal pressure down to 0 or even to a negative pressure in order to start the breath. So if you look at one pressure support breath, you see here the airway pressure and the flow. So this is expiration, this is inspiration. And when you superimpose the esophageal pressure on this tracing, so you see when the patient is starting inspiratory activity, he's starting far before he receives any pressure support. And this is because he has to use his or her inspiratory muscles while he or she is still expiring. And there is still expiration because the pressure gradient indicate that the flow should go from the alveoli to the ventilator until the pressure becomes negative. So in this situation, it's very helpful to add external PEEP to be as close as possible to the internal PEEP of the patient, and in which case you markedly reduce all this part of the inspiratory effort, which is also called inspiratory threshold load. And many studies, many studies have shown repeatedly that if you add external PEEP in this situation, you decrease the work of breathing. In this study we did with Jordi Mancebo, we used the P.1 as a surrogate for work of breathing, and showed that when the work of breathing was decreased, this was usually indicated by a lower P.1. When the work of breathing was increased, it was shown by an increase in P.1. So external PEEP has no effect until 80% of PPI is reached, and PPI decreased work of breathing induced by decreased work of breathing induced by PPI. The reason we used P.1 in the previous study was that it's difficult to measure intrinsic PEEP when patients are spontaneously breathing. And this is very bad because this is the time where it would be needed. And one of the reasons why it's complicated is when you do an occlusion like that, for instance, to measure the passive pressure. In fact, what you get on the airway pressure, if you see the curve here, is to a large extent due to the contraction of the expiratory muscles. So you do measure a pressure, but this pressure is not dynamic hyperinflation. It's dynamic hyperinflation plus expiratory muscle activity, and if you titrate your external PEEP on that you may come to very high level. So we need other techniques to measure intrinsic PEEP. One of this technique could be the ultrasound, which Johan Gulliger described this morning, where you can follow the diaphragm activity and the diaphragm motion. And you have here an example where you have the airway pressure tracing, and on the same trace you have the diaphragm activation. And you can see that the diaphragm is starting something like 350 milliseconds before the ventilator. So this delay is caused by intrinsic PEEP. So using this tool you can adjust the external PEEP to better match patient's activity and ventilator setting. You can also use the electrical activity of the diaphragm, which we already described this morning. And you will see again the same delay between the beginning of the EDI and the time at which the ventilator is starting. In this nice study by Giacomo Bellani, they showed that the auto-PEEP could be decreased by using NAVA, for instance. And one of the funny tracing was to show that with NAVA there is an immediate increase in pressure reaching the patient auto-PEEP, and after which you have this progressive increase in the airway pressure. Just to show you an example from St. Michael's Hospital, where you have a patient under pressure support, you have no EDI, so you have no good idea, except if you look carefully at the flow trace, you see that it starts to be decreasing far before the beginning of pressure support. But of course it's much easier if you have the EDI, because you can measure the delay between the EDI activity and the start of pressure support. If you use NAVA, you immediately start at the same time of the EDI activity, and you have the same funny shape that I showed you from the Bellani's paper. So different technique can be used, and ultrasound and EDI seems very attractive on top of the esophageal catheter. I will finish by saying having a high intrinsic PEEP does matter, and we have data showing, for instance, that patients failing weaning trial increase their intrinsic PEEP. So there is a clinical consequence of that. I will finish that indicating that PPI may be a cause of weaning failure. Stop that and be happy to answer your question if I have time. Thank you.
Thank you very much, Laurent. Actually, we would suggest that we take the questions after the second speaker, if you're right.